If you've ever sat in a doctor's office, heard the word surgery, and felt your stomach drop because something about it just didn't sound right, this video is for you. Can an operation be offered too quickly, even when it sounds routine and respectable? Yes, absolutely. And there are a few procedures that, in the wrong situation, I personally would not rush toward at all. I would slow everything down, ask harder questions, and sometimes walk out for a second opinion. I'm Dr. Kevin Adewale, and this matters to me because helping people avoid unnecessary procedures is just as important as knowing when surgery truly saves function, independence, and life. And by the end, you'll know which 5 recommendations I would question hardest and what to ask before saying yes. Surgery 1. Knee arthroscopy for arthritis. One thing I notice again and again is how often people think a worn, aching knee must have something loose inside that simply needs cleaning out. It sounds logical, doesn't it? If the joint hurts, maybe a surgeon can go in, wash out the debris, trim a bit here and there, and the whole thing will move smoothly again. To be honest, that story is emotionally satisfying, but biology does not always cooperate with a story that neat. Arthritis is not like crumbs trapped in a carpet. It is more like the tread on a tire slowly thinning, the shock absorbers stiffening, and the alignment drifting all at once. The joint surface changes, the lining gets inflamed, the bone underneath reacts, and the muscles around the knee often weaken because pain makes people move less. So when someone says, just clean it out, I immediately think, clean out what exactly? If the whole environment of the joint has changed, a quick tidy up inside the knee may not fix the deeper reason it hurts. There was a famous study published in the New England Journal of Medicine in 2002 by Bruce Moseley and colleagues that put this idea under a very uncomfortable spotlight. They randomized 180 patients with knee osteoarthritis to arthroscopic debridement, arthroscopic lavage, or sham surgery, meaning some patients had the skin incisions without the actual surgical treatment, and the outcomes were not better in the real surgery groups. Which, if you think about it, is actually quite remarkable. People went through the whole ritual of surgery, yet the extra mechanical work inside the knee did not outperform placebo surgery. Now, a lot of you will be wondering, does that mean knee arthroscopy is always useless? No, and here's the thing. If somebody has a true locked knee after an injury, a loose body, or a specific structural problem, that is a different conversation. I'm not going to overstate the evidence here. But for straightforward knee arthritis, honestly, this is not a procedure I would sign up for quickly. What would I do tomorrow if it were my own knee? I would start with a boring answer because boring answers often work. I would get serious about strengthening the quadriceps and glutes. I would look at body weight if that was relevant. I would use pain relief strategically rather than continuously. And I would ask whether a structured physiotherapy plan has actually been tried properly. Stay with me because this matters. A stronger leg changes how force travels through the joint every single step of the day, and that can matter far more than a camera and a washout. And one more thing, if stairs hurt, that does not automatically prove the knee needs a scope. It often means the muscles that control the knee are not sharing load well. Small daily changes like sit-to-stands, step-ups, and consistent walking can calm that system down more than people expect. Right then, moving on. Surgery 2, meniscus trimming for a degenerative tear. This next one overlaps with the knee, but it deserves its own warning because it gets sold with a different label. Someone has an MRI, the report says meniscal tear, and suddenly that scan starts to sound like a sentence. People hear tear and imagine a ripped shirt that must be stitched or cut away. You know the feeling. The image looks dramatic, so the solution starts sounding obvious. But a degenerative meniscus tear in middle age often behaves less like a fresh rip in fabric and more like a crack in an older leather belt. It reflects wear, age, load, and tissue quality. The real question is not whether the scan shows a tear. Scans show all sorts of things. The real question is whether that finding is truly the reason for the pain and whether removing part of the meniscus will help enough to justify losing cushioning tissue that the knee may miss later. In 2013, Rein Sichvonen and colleagues published a sham surgery trial in the New England Journal of Medicine on arthroscopic partial meniscectomy for degenerative medial meniscus tears. The surgery did not beat sham surgery for pain and function. Then a BMJ trial in 2016 compared exercise therapy with arthroscopic partial meniscectomy in middle-aged adults with degenerative meniscal tears and found exercise therapy performed at least as well with better thigh muscle strength early on. That is the sort of evidence that makes me stop and lean back in my chair a bit. I also tell people not to panic over the word tear. Hair goes gray, skin wrinkles, and joints show age on scans. That is not me dismissing pain. It is me protecting you from the trap of assuming every abnormal image demands a blade. Why am I so firm about this? Because every unnecessary procedure has a cost, even when it goes technically well. There is anesthetic risk, recovery time, money, lost confidence, and the emotional sting of putting your hope in something that was never very likely to solve the real problem. Because what is the meniscus doing? Think of it like a rubber wedge and load spreader. It helps distribute force. If pain comes mostly from a knee that is aging, a bit inflamed and underconditioned, shaving away tissue may treat the scan more than the person. To be honest, I worry when imaging becomes the loudest voice in the room. Symptoms matter, function matters, context matters. So my practical tip here is very simple. Before you let anyone schedule this operation for a non-traumatic degenerative tear, ask 3 questions out loud. Have I done a real course of supervised rehab? Do I actually have true mechanical locking rather than clicking or catching? And if we wait 8 to 12 weeks while I strengthen the joint, what exactly is the danger? A good surgeon should welcome those questions, not rush past them. And if you're finding this useful, which I really hope you are, then please do hit the like button and subscribe to the channel. It genuinely makes a huge difference to how many people this reaches, and that is why I make these videos. Share it with someone who has been told they need a procedure and does not yet know what to ask. Okay, so now let's talk about the spine, because this is where fear really starts driving decisions. Surgery 3, spinal fusion for nonspecific chronic low back pain. I have enormous sympathy for people with persistent back pain. It can wear you down quietly. It steals sleep, patience, confidence, movement, work, even parts of your personality. So when someone says, we can fuse those painful levels and stabilize the problem, I completely understand why that sounds attractive. The promise is simple. Make the painful segment stop moving, and the pain should stop too. Honestly, if the body worked that cleanly every time, life would be much easier. But backs are not stacks of unstable bricks. They are living systems with discs, joints, nerves, muscles, fascia, habits, fear responses, and movement patterns all talking to one another. Pain in the lower back, especially when it has gone on for months without major nerve damage, major instability, fracture, infection, or cancer, often behaves more like an overprotective alarm system than a single broken hinge. And here's the thing. Bolting one part of a complex system does not always quiet an alarm that has become sensitive. The evidence here is sobering. The BMJ trial led by Jeremy Fairbank in 2005 compared lumbar fusion with an intensive rehabilitation program based on cognitive behavioral principles in people with chronic low back pain. Surgery did not produce a dramatic runaway advantage. Then long-term pooled follow-up of 3 randomized trials, published in the Spine journal by Mannion, Brox, and Fairbank, found that over many years, fusion was no better than non-operative care for improving pain and disability in chronic low back pain. That is not a small detail. That is the central detail. Now I need to be careful here. I'm not saying spinal fusion has no role. It absolutely can when someone has deformity, instability, certain cases of spondylolisthesis, fracture, or severe nerve compression in the right setting. I'm talking about the very common situation where the message becomes, your scan looks bad, your back hurts, therefore we should fuse it. A lot of you will be wondering whether a scary MRI automatically means surgery makes sense. No, not remotely automatically. What would I do instead, tomorrow, in real life? I would ask for a clear diagnosis in plain English. I would want to know whether the proposed operation is addressing a definite pain generator or just an abnormal image. I would commit to a properly structured program that includes progressive exercise, walking, sleep repair, and, where needed, pain education, so the nervous system stops interpreting normal movement as danger. That sounds too simple, I know, but simple does not mean superficial. If I had chronic back pain myself, I would give a good non-operative plan enough time to work. Not 3 hopeful days, not 1 distracted week. I mean a real stretch of guided effort with measurable goals, because the body usually needs repetition before it trusts movement again. Now, I'm not going to sit here and tell you this is a magic bullet. It isn't. Some of the more dramatic claims you'll see online are well ahead of what the research actually supports right now. But what we do know is solid enough to take seriously. People with chronic back pain often improve when they rebuild capacity rather than chasing the fantasy of a perfect scan. Now, here's something that surprised many people when the studies first landed. Surgery 4, vertebroplasty for common osteoporotic compression fractures. On paper, vertebroplasty sounds brilliant. Someone has a painful spinal compression fracture from osteoporosis. A needle goes in, cement goes in, the vertebra gets reinforced, and the pain should melt away. What is not to like? The whole idea has a satisfyingly engineering feel to it. A cracked wall gets filler. Problem solved. Except the human body is not a garden wall. Pain after a compression fracture can come from inflammation, healing, posture changes, muscle spasm, fear of movement, and the broader fragility that allowed the fracture to happen in the first place. So the question is not whether cement can be injected. It can. The question is whether doing that reliably helps more than the powerful placebo effect and natural healing that follow any convincing procedure. Two sham-controlled trials published in the New England Journal of Medicine in 2009, one led by Rochelle Buchbinder and another by David Kalmes, found no significant advantage for vertebroplasty over sham procedures for painful osteoporotic fractures. Then the Virtus 4 sham-controlled trial in the BMJ in 2018 again found vertebroplasty did not deliver superior pain relief compared with a sham procedure. You know, when different studies keep pointing in the same direction, I pay attention. Does that mean I would never want anyone touching a spinal fracture? No, because context still rules. Some fractures are unstable. Some symptoms are unusual. Some people need hospital care, bracing, osteoporosis treatment, and a careful plan because the bigger danger is the next fracture. I'm not going to overstate the evidence here. But if I were offered routine vertebroplasty for a standard osteoporotic compression fracture without red flags, I would want a second opinion before anyone opened the cement. My practical tip is this. If you or someone you love gets one of these fractures, do not make the entire conversation about pain today. Ask what is being done about bone health tomorrow. Ask about a DEXA scan, vitamin D if appropriate, calcium from food, resistance exercise when safe, balance training, and medication for osteoporosis when indicated. Preventing fracture number 2 matters more than performing an impressive-sounding procedure for fracture number 1. And please do not miss the bigger osteoporosis picture. After one fragility fracture, the skeleton is telling you something important. That is your moment to review protein intake, home fall risks, vision, medications that increase dizziness, and whether you are getting enough daylight and movement. Right then, one more area where surgery can sound much more precise than the evidence really is. Surgery 5, shoulder decompression for impingement-type pain. I have a habit of getting nervous whenever a painful shoulder is described as something being pinched that simply needs more space. Why? Because that explanation is tidy, visual, and easy to market. If a tendon is rubbing under a bit of bone, shave the bone, create space, end of problem. It sounds almost irresistible. But shoulders are more like orchestras than door hinges. The rotator cuff, shoulder blade, posture, movement timing, tendon sensitivity, and load exposure all have to play together. Pain can build because the tendons are irritated and the system has lost rhythm, not because a tiny roof of bone is behaving like a villain in every case. So when I hear decompression, I ask myself whether we are fixing a true mechanical bottleneck or simplifying a much messier story. The CSAW trial published in The Lancet in 2018 looked at arthroscopic subacromial decompression for subacromial shoulder pain and found only small differences that questioned the value of the operation itself. A BMJ placebo-controlled trial from the Finnish FIMPACT group in 2018 compared decompression with diagnostic arthroscopy and exercise therapy, and the surgical decompression did not show a clinically relevant benefit over placebo surgery. That should make any honest doctor pause. A lot of you will be wondering, so what should I do with shoulder pain that keeps coming back? First, make sure the diagnosis is right. A full-thickness rotator cuff tear, repeated dislocations, or major weakness is a different conversation. But if we are talking about the classic impingement-type story, I would give structured rehab a real chance before letting someone shave bone off my shoulder. And here is the daily tip I would use myself. Spend 10 minutes a day rebuilding shoulder mechanics. Slow range of motion, scapular control, rotator cuff strengthening, and then graded return to overhead activity, not random internet exercises. A deliberate plan. To be honest, shoulders often reward patients if you load them intelligently instead of babying them forever. The other trap with shoulders is bouncing from rest to injection to rest again without ever rebuilding strength. Tendons like sensible loading. They hate chaos, so if all you have been told to do is avoid using the arm, I would push for a better rehabilitation plan. So what ties all 5 of these together? It is not that surgery is bad. Surgery can be miraculous. It can restore sight, relieve true nerve compression, fix fractures, remove cancers, and save lives. The problem comes when a procedure gets offered because the story sounds clean, the scan looks dramatic, and everybody in the room wants certainty. But certainty is seductive. Biology is messy. Honestly, the biggest red flag is not always the operation itself. It is the speed. If nobody explains the natural history, the alternatives, the evidence, the downsides, and the option of watchful waiting or rehab, slow the process down. Ask what happens if you do nothing for 6 weeks. Ask what outcome the surgeon expects in someone exactly like you. Ask what trial supports that expectation. Good medicine can handle good questions. Thank you for spending this time with me. I really do appreciate it. If this helped you think more clearly about a recommendation you or someone you love has received, please like the video, subscribe to the channel, and share it with somebody who needs it. And if you want to go deeper, I've done other videos on joint pain, back pain, osteoporosis, and when scans help versus when they confuse the picture. So have a search around the channel and keep learning with me.